Well, welcome everybody. This is part 2 of 2. So after today, you don't have to listen to me anymore. That's good. And we're going to be talking about dementias. And again, my name is David Vossler. I think I go by Dave, as Terry said last week. I prefer that. I think everybody, most people were here last week, and if not, hopefully you had a chance to look at the YouTube video, which is on the website, on the church website, and we'll have another one for this session as well if you want to go back and reference something or you have questions. I got a lot of questions during last week's talk, and then immediately afterwards, and even a follow-up one. And they were all excellent. Actually, really, a couple of them really made me think. So I appreciate those. And so don't hold back today. I think I have maybe a little bit fewer slides today than last week, so I think we'll have a little more time for conversation as we go. I'm going to be mindful of the time and get started. You remember that we talked about the fact that I'd be covering the 4 main types of dementia, and we covered 2 of the main types, the 2 most common types. Number 1, the most common type is what? Alzheimer's disease, yes, named after a German anatomy professor, I'm probably not pronouncing his name correctly, but Alzheimer. And it's not old-timer disease, because it's Alzheimer. Okay. And then we talked about the sign, or the other type we talked about last week was what? Vascular dementia, right? Which is a fairly common one. It's not a uniform, because it just depends on what kind of happens to the person. Okay, and then as we were going, we talked about the signs and symptoms. I really didn't talk much about the diagnostic tests, and I didn't get into medications or treatment at all. I did talk about risk factors and how you can mitigate those risk factors through things like good diet, exercise, avoid alcohol, don't smoke, and get good, and exercise your brain. Your brain's like a muscle, right? If you want to preserve it, make it strong, use it, and use it for hard things, as much as that's kind of difficult sometimes. All right, so today we'll talk about the other 2 types of dementia, which are frontotemporal dementia, you see here, and then Lewy body dementia. And I thought I'd put a face to some of these types of dementia, and you'll recognize this face, of course. This is a very popular president, our 40th president in the United States, and Ronald Reagan, who had very late onset Alzheimer's disease, and he had it for at least 10 years, probably before that. The press corps in Washington unfortunately gave him this sort of nasty nickname, the empty suit, because they would ask him questions and like he really wouldn't say anything. He didn't really have any substance, and that's sort of a sad, sarcastic commentary, I guess, on Alzheimer's disease. But he did live to 93, and so he lived quite a long life, which is a little unusual actually with Alzheimer's disease. We talked about all of this stuff last week, the genetics, the pathology, some of the things that, we've talked to doctors about, so it may have been a little over your head, but I don't really like to hold back with people and treat you like you can't understand this stuff, because I think it helps, particularly if you have a family member or loved one with these conditions, to understand a little bit. And I skipped over vascular to talk about that as well. All right, I will speak up loudly. So frontotemporal dementia, if you know the 4 lobes of the brain, you'll say, oh, I get it, I get which ones are involved. We have 4 lobes to our brain. We have the frontal lobe, which is up in the, not surprisingly, in the frontal part of the brain. You have the temporal lobe here, which I think has to do with the Latin word tempus. They thought it had to do with time. I said this last week, it really doesn't have to do with time, it has to do with memory. So the frontal and temporal lobes get involved. In Alzheimer's disease, it's more the parietal and occipital lobes back here and the temporal lobe. But in frontotemporal dementia, it's frontal and temporal, as the name obviously indicates. Thank you so much. There we go. All right. This is a little bit less common, but it's still problematic. About somewhere between 2 and 10% of all dementia cases are due to frontotemporal dementia. And unlike Alzheimer's disease, as I mentioned, which involves the temporal lobe in the back of the brain, this tends to involve more front areas. There are two types. There's no quiz at the end. You don't have to remember these. The one that's a little more common is behavioral variant, which unsurprisingly has behavioral kinds of problems, behavioral signs and symptoms and problems. A famous person, I'll show you his face in a minute and ask you to recognize the face. Famous actor is the primary progressive aphasia type. Aphasia means language problems, and so that's what this famous actor has. So let's go through the little more common type, behavioral variant. This begins, there's a wide range, as you can see, age of onset. The average is about 58 years. This actor, who I'm going to disclose in a few minutes, is 69, and he's in the kind of the end stages. So it's fairly typical. Early signs are often mistaken for a midlife crisis. I think Fred is having a midlife crisis. He's just, losing it kind of. There can be depression or other psychiatric illnesses. There can be recurrent job loss, new marital discord. If you have a lifetime of marital discord, that doesn't count. But if you have new marital discord, maybe that you have to think about this. Okay. Core features: apathy, just not wanting to do anything. Loss of social graces, saying inappropriate things, just not filtering stuff, disinhibited, loss of sympathy, loss of empathy. Making errors of doing and not doing things, so like doing things inappropriately, forgetting to do things, abandoning your family duties, whatever those may be. For me, it would be mowing the lawn. If I don't mow the lawn, Michelle would be like, no, I'm just kidding. All right, make errors, violating personal boundaries. So again, this is what the frontal lobe is all about. We talked about this last week. The frontal lobe is involved in executive function, attention, inhibiting certain impulses, attending to things, using judgment, personality, even humor. People can violate personal boundaries, approach strangers with unwanted questions, tactlessly commenting on a person's attractiveness, weight, or social position, ignoring or trivializing your spouse's major events, things like when your spouse has cancer or job loss, family death, and then sort of repetitive, even compulsive kind of behaviors like overeating. All of these things they're not like absolutely diagnostic of this, but these are the kinds of things that you'll see kind of cluster together in this particular condition. And as a syndrome, it can sometimes be caused by Alzheimer's disease. It can be caused by psychiatric illnesses, other dementias, even other medical conditions. But most cases are due to this specific disorder, a disease called frontotemporal lobar degeneration, or FLD, excuse me. About a fifth are genetic, and the treatment, unfortunately, is not what we would like it to be right now. It involves behavior management, psychiatric medications to kind of rectify these psychiatric problems, and caregiver support. The caregivers are really, it's difficult. It's difficult in this problem because when you get into behavioral problems, that's sort of an order of magnitude often worse than dealing with sort of, if you will, just hard medical issues. If it's due to Alzheimer's disease, then there are some new infusion therapies that are given by intravenous infusion. We'll talk about those in a minute when I come back to treatment. So primary progressive aphasia is the other variant, a little less common, of frontotemporal lobar degeneration or frontotemporal dementia. It's early and prominent progressive loss of language function, but without loss of memory function, interestingly enough. So memories are pretty intact, but language is just going. It's just getting worse and worse. Language skills get worse, so they have difficulty speaking and understanding and reading and writing. It's fairly rare, but it is the other type, and you don't need to know the two different variants. I'll just say that one, it kind of says it for itself, non-fluent. Fluent, obviously, fluency means the flow of speech, putting words together in a smooth sentence, using adjectives and adverbs and prepositions and nouns and verbs. correctly, arranging them grammatically correctly. That becomes difficult with the one subtype, and the other is the meaning. The words don't mean anything. So they're sort of empty words that can occur, and naming problems. So don't worry about the two subtypes. You're not neurologists. You don't have to come up with those, but just be aware that there can be different kinds of language problems in this. So who is this guy? Bruce Willis. And Bruce Willis and his family have been very public about this, and I think it's a good thing. Because, it puts a face on this condition. This isn't a condition that lives in the shadows. Nobody has to be ashamed of it. It is unfortunately a very difficult one, as I said. So Bruce is 69 this year, sometime this year, and next year he'll be 70. He's sort of in a really progressed stage. He mostly has the language variant we talked about. And he really, at this point, I don't think is saying very much of any words at all, which is really a pity. Obviously a big, strong, healthy guy. Other than that, medically very healthy. So the lifespan of these is 3 to 10 years. If it runs in families, and there are about 15 to 20% of these cases are familial or genetic, if you will, then they often will also develop Parkinson's disease or ALS, which used to be called Lou Gehrig disease. We don't call it that anymore because he's a famous baseball player that got it, but that doesn't, they actually discouraged the use of Lou Gehrig disease. Parkinson was a British physician who described Parkinson's disease. So it's okay to give a physician's name to a disease or a researcher's name, but they don't like to give people's names who suffered from the disease. That's why.
I have a question.
Yes, ma'am. Question.
Over here, David.
Oh.
So the lifespan after diagnosis, is that just for the aphasia or for both entities?
Well, I would say it's for both. The behavioral variant is the most common type, and that tends to run 3 to 10. It's pretty variable, and Bruce Willis has had his now. Publicly they've been aware of it for, I don't know, must be at least, seems like 5 or 6 years to me. So, yeah, good question. Anybody else? I'm sorry. Okay, throw something at me if I don't see you. Okay, no, I actually don't. Okay. Imaging and pathology. So up at the top, you see these are MRI scans, and I'll tell you just a little quick anecdote. I did my neurology training at Boston University from 1984 to 87. So 84, if you do the math, that was 40 years ago. We didn't even have MRI scans at the time. We had CT scans. And around 86, we were allowed to order 4 MRI scans a year. Each of the residents could order 4 a year, so you had to pick very carefully. And we had to send them to Mass General Hospital, which was the only hospital in the entire New England states that had an MRI scanner. It was pitiful. It was a terrible scanner by today's standards. But I will tell you, I remember I got tingles down my spine that first MRI I saw. I was like, oh my goodness, wow, we're really it's like looking at, this is a pathology specimen, this is an autopsy specimen of the gross brain that's been sliced here. It was almost like looking at that, and we were just flabbergasted in 1986 that we got our first MRI scans. But it's come a long way. Right? The point of all of that, that's a side note, but here's this frontal lobe atrophy, here's the substance of the brain, and the spinal fluid it's massive because the brain has shrunk away. And it's not water on the brain or hydrocephalus, it's sort of just a shrinkage of this, and the water just replaces it because the skull bone's fixed, right? So water has to come in to fill it up. Look at the temporal lobe. Even down here in this pathology specimen, this is beyond severe. It's like unbelievable how much atrophy is seen in that particular case. So that's what you see in either the gross tissue specimen or the actual brain. Under a microscope, you see things that are called Pick bodies. And back when I was a resident again, that's what we called this. We called this Pick's disease. So we knew Alzheimer disease was the most common. There was vascular, there was Pick disease. That was it. That was what we knew. They don't use that term anymore. Pick bodies do exist. They're that protein tau that I was talking about last week. Dave, wait a minute. You talked about tau in Alzheimer disease, so now we're talking about tau in frontotemporal dementia. Yeah, but it works in different ways. And also there can be other things like ubiquitin and other proteins in addition to these tau proteins. You can get ubiquitin or you can get TDP43 proteins that they get in and they poison the cells. They cause the nerve cells that do our thinking. They balloon them out and they poison them and they die in this particular condition. All right, so that was frontotemporal dementia. Before I move on to the final one, which is dementia with Lewy bodies, does anybody have any questions about frontotemporal dementia? Or want to share like an anonymous case or something? Okay. I don't know if you could all hear that, but she was just saying that they have a friend whose husband he's 67, so 2 years younger than Bruce, but it's my age, right? And they've seen all of those signs.
So what is available in the way of, so there's no medication about care and that's,
yeah, psychiatric care.
Exhausting.
It's exhausting, right? What about care? Caregiver support is important. Bringing in, help to the home. Eventually, like all patients with dementia, often they'll wind up needing memory care, which is very, very expensive. Over $10,000 a month. Now, can you imagine that? We just don't have treatment for it, and using psychiatric medications to prevent any of the agitation, either if those kinds of mood disturbances. You can use standard antidepressants and to try to treat if there's depression, anxiety. It's a difficult condition for everybody. I think maybe the worst of the dementias. Maybe.
I know someone died who had this also.
Okay. Well, Claire's got a twofer, so she knows someone who had dementia with Lewy bodies. And someone did talk to me after last week's meeting about someone they knew, and I suspect that person may also have dementia with Lewy bodies. So Lewy body dementia is an umbrella term. It can include the dementia that occurs in some people with pre-existing Parkinson's disease, like it's really advanced Parkinson's disease. But more commonly, it's a condition all by itself. The pathology, these Lewy bodies, are seen in both conditions, but this is where the dementia precedes the other movement signs that are seen with Parkinson's disease. And it's not that uncommon. 4 to 7% of all cases of dementia. Of course, probably 80% is is Alzheimer's disease. So the core clinical, I only have 3 slides here, by the way. The core clinical features, and I think in this, one of our members talked to me about this, related to this person that they know, and I'm not making that diagnosis, by the way, if that person's here, but it sounded like it to me superficially. I didn't see the patient, I don't know. But fluctuating cognition, again, cognition means thinking. That's what we neurologists say, with marked variations in attention and alertness. These attention issues can become so prominent that patients themselves can become completely unresponsive, as if they're in a coma. And I had a case of this in the hospital. They had sent the patient to me. They were wondering if these episodes of unresponsiveness, which by the way lasted for many, many minutes, even hours, they were wondering if there were some sort of epileptic seizure where they were fine and then literally checked out, they're in a coma. Interesting, the EEG was completely normal. So the EEG is where you put the electrodes all over the head and you measure the brain waves, and like, wow, this patient's awake, but they look like they're in a coma. What's going on? That they'll have periods where their speech is just illogical or incoherent, almost like the language disturbance that Bruce Willis has with frontotemporal dementia. But they also have other things. They'll have recurrent visual hallucinations. They'll be seeing very unusual things when they fall asleep and they get into dream sleep, called REM sleep. They will have behavior disorder. They'll act out their dreams. And then as things progress, they will get these Parkinson's disease-like movements. What's the key triad of Parkinson's disease? What we try to teach all the medical students: bradykinesia, which means slow movements,
Just everything's really slow, as you know. If you've seen Michael J. Fox is a good example of someone with very, now unfortunately very advanced, young onset, by the way, Parkinson's disease. So they get very slow movements, they get the tremor even when they're resting. It's not so much a movement tremor, it's more when they're at rest. They have this terrible tremor, which will sometimes get a little better when they actually try to move. And then the rigidity. If I were to take their arm or their leg and move it, we say it's like a lead pipe. It's like, it'll bend, but it's stiff in all directions, and flexion and extension. So those are the characteristic. That's the triad of Parkinson's disease that was described, back in the 1800s and been worked on since then. So they'll look like that. So this is a person you probably all recognize who died of Lewy body, Lewy body disease. Does anybody know who that is? Robin Williams, yes. And very sadly, he took his own life because he knew what was happening to him, and it was really quite tragic. It just added insult to injury for the family, right? He was sick enough, and then on top of that, he committed suicide. So one of the key things that I'm going to give this talk in one session, not two, to my colleagues, and it's really important that they remember when you suspect that, never give antipsychotic medications, the medicines that we use to treat like schizophrenia, psychosis. Those are very common condition, right? You don't want to give that to these people. It will make them very, very ill and put them in a hospital. Very important to remember that. They have problems with visual, spatial abilities, have relatively preserved memory and naming, but their attention is bad. They'll fall. They have posture instability. Syncope means fainting. They'll just pass out when they stand up. Their blood pressure just plummets and they fall. Had a very good friend who was a co-Boy Scout leader with me, and I think this is kind of what he had toward the end. And then other bowel and bladder problems, excessive sleeping during the day, decreased sense of smell, and then these other things you can see are sort of psychiatric kind of symptoms. So a very sad one, and again, we don't have a specific treatment for that. Okay. Any questions about dementia with Lewy bodies? Okay. All right. And Claire's got the record. She's knows somebody who's had both of those conditions, unfortunately. Okay, so tests. Tests. A lot of people are like, well, okay, so there's 4 different types. So how do you differentiate those 4 different types diagnostically in the clinic or in the hospital? And I've seen all 4 types repeatedly over time. Well, there are screening tests, and some of you may have seen these done. And your primary care doctor can do these screening tests. Take about 10 minutes or so. There's the mini mental state exam, or the Montreal Cognitive Assessment. This one's a little newer. I like it a little bit better. This one is a little too heavily weighted on certain aspects of how we think. This one's more evenly. It kind of explores all areas of how people think a little more equally. We'll talk about that in a minute. There is a full neuropsychological testing that can be done. This lasts usually somewhere between 6 and sometimes 7 hours, and it's a long day. You take a break for lunch and come back in. It's done with a PhD neuropsychologist across the table from you, or their assistant. They administer all kinds of thinking and logic and mathematical and attention and language tests, and it's quite exhausting. The patients go home exhausted at the end of the day, as you can imagine. We can do lumbar puncture, where we put a needle not in the vertebrae but between the vertebrae and get into the spinal fluid sac and remove the spinal fluid, and can measure the amyloid level that's in the spinal fluid and the tau level that's in the spinal fluid. And if you remember back to last week, those are the 2 proteins that are abnormally accumulated in the brains in Alzheimer's disease. amyloid beta, or beta amyloid, sometimes we call it, reverse it, is high in the brain, but it's low in the spinal fluid. It's because it's accumulating in the brain and it's not getting out into the spinal fluid and getting flushed out of the system like it should be. Interestingly, the tau, another protein, and the phosphorus tau, those are elevated both in the brain and in the spinal fluid. So you have to kind of remember that when you're a doctor, like, okay, which one's elevated in both and which one's only elevated in the brain? Well, it's the amyloid that's only elevated in the brain. We'll do all these standard tests that I had done. Last week I saw my physician for my annual Medicare exam, and she ran all this stuff. We like to check for vitamin prop. We see if there's any vitamin deficiencies, see if there's any thyroid deficiencies when memory is an issue. Those are very rare, actually, and kind of overblown. A lot of people are like, oh, you need to take supplements. There's no evidence that unless you really do have vitamin B12 deficiency, which, I mean, it does occur, but it's way rare. And thyroid conditions are not being treated, except for those things. You don't commonly find those. Now we can measure this p-tau 217 protein in the blood. This just happened. This is from just 2 months ago. It was in the journal of the American Medical Association. It was a big Swedish study, and they found that measuring the tau in the blood and even measuring 2 different forms of the amyloid protein in the blood, they've been able to come up with what they think is a pretty reliable blood test. Now, it's not approved. I don't know if Medicare would pay for it in the United States. Not approved in the United States. There's no guidelines. This is new stuff. But I think it's going to filter into practice. And, if it were me, I'd much rather have a blood test to see if I have Alzheimer's disease than a spinal fluid and a lumbar puncture. I mean, it's not as bad as most people think, but it's still no fun. I mean, a blood test, we can all do that, right? Because we have. I've already talked about the MRI and the PET scan. I went over the MRI, a couple of frontotemporal dementia today, and last week we talked about the MRI of Alzheimer's disease, and we talked a lot about PET for Alzheimer's disease. So I won't go over those today again, just for the sake of time. But I wanted to talk about these screening tests. So some of you may have seen these things, the mini mental state exam versus the Montreal cognitive assessment. Again, can be done right in the exam room with your primary care doctor or a neurologist or whomever. The mini mental state exam was described almost 50 years ago. It's not perfect. A lot of doctors use it, and that's fine. It's copyrighted, so you have to buy the original forms from this psychology supply company because they make money doing that, right? And it's got a copyright on it. So there's that. The new Montreal cognitive assessment that was developed more recently here, 28 years ago, and it's a little more sensitive, and the normal ranges are here, and that's really for the doctors. So I'm gonna, as like I say, I'm gonna give this talk to the doctors just to remind them what the cutoffs are, and you don't have to know that. But here's what I would like to read for you. These should be done as just a screening tool for patients or people who come in with cognitive complaints. And they're a diagnostic adjunct. It adds to your clinical assessment. You talk to the patient, you talk to the family, you do examination. You can do this. All by itself, this doesn't indicate dementia. And if you score in the normal range, that doesn't mean you don't have early dementia. So people who say, well, I scored great on this test, therefore I'm a genius or whatever. No, that's not really true. They should not serve as the sole criteria for diagnosing dementia or differentiating between the 4 different types of dementia. But they can kind of quantify as quantitative measurement of how the person's doing, and you can follow that over time to see if there's progression. So that's where we have these screening tests. The neuropsychological testing is much more complicated and much more accurate, but it takes so long, and one PhD is going to spend an entire day with a patient. You can imagine there's not enough PhDs to go around doing these tests. So this slide is busy. This is taken from this brand new article that just came out about 6 weeks ago in the Journal of American Medical Association. And I don't want to get into the weeds here on this because it's just way too much, but basically you're measuring this p-tau 217, and you measure the percentage, so p-tau versus non-p-tau that's in the blood. And then you can also look at the beta amyloid 42 versus beta amyloid 40 ratio. And basically what they're showing is that for primary care doctors or for specialists in a dementia clinic, it's going to enhance both of their diagnoses. You know, primary care doctors are about 63% accurate diagnosing dementia. Dementia clinic doctors are about 80% accurate. When neither are 100, this test is about 91% accurate. So this looks like it's going to be a good additive test that will help refine and make our diagnosis more accurate. So there's that. So why do we go through all this, right? This is a long talk. We do all these tests, some of them putting things in people's back. We're doing brain scans, PET scans with nuclear medicine materials. The reason is treatment. Some things that we talked about, dementia with Lewy bodies, and frontotemporal dementia. We don't have specific treatments, but we need to differentiate those people from those that have Alzheimer's disease. We do have more treatments for Alzheimer's disease. If you don't have the right diagnosis, you're not going to treat people correctly. So you've got to choose the right treatment based on what you're dealing with. The goals, of course, are simple: improve memory and stop the progression of Alzheimer's disease. Make sure that patients are taking their medicines and make sure they're taking the right medicines and there are no drug interactions. Because sometimes wrong medicines can kind of make things worse. Drugs that will temporarily and mildly help memory, just helps memory, boosts memory kind of temporarily, include ones that you may have heard of. Aricept was the old brand name, but it goes by the trade name, the generic name donepezil, rivastigmine, or Exelon, that comes as a tablet or a patch, because some of these have a little bit of GI side effects, so the patch will boost memory without as much GI upset compared to the tablets. And then the other one is galantamine, or used to be called Razidine. So GI issues are sometimes occur in these in some patients, not everybody, not most people, but a fair number do get it. And that can be a little bit of a game stopper. They can get a little bit of urinary symptoms like incontinence or urinary retention. They can get a little sedated with it. I don't hear that too often. This is pretty rare, low heart rate. That's for sort of mild to moderate Alzheimer's disease, by the way. Again, this is just for Alzheimer's disease. For mild, moderate, or even severe Alzheimer, then you can turn to Namenda, which goes by the generic name Memantine. All of these drugs are available as generics now, so the prices come down a lot. Constipation, headache, dizziness, and sedation are some of the side effects. And there was a newer version of this galantamine over here. It's called, this name, Zunavil. By the way, those names are just made up by companies, and they're supposed to sound tricky and good and easy to pronounce. So, because no patients can say benz-galantamine, right? So they like, Zunavil. This has a little bit less GI side effects. But these are not, treating the problem in the sense of making Alzheimer's get better or go away. They're just improving thinking a little bit, which we're grateful for, and that's good. But it's not a cure for the problem. For patients with dementia with Lewy bodies, and Claire asked about this too, you can try other things like dopamine, or medications that work on dopamine receptors, but you've got to watch out very carefully, make sure that you're not worsening the confusion or hallucinations. And for any of these conditions, especially where behavior is a problem, even in Alzheimer's disease, treating with things like selective serotonin reuptake inhibitors, treat depression, or bupropion is another one, those can be helpful. So again, more for the doctors, more for this talk I'm going to give later this month to my colleagues. You don't have to remember that, but that's where we are.
Hello?
We've got 2 questions. Yes?
What about short-term memory in testosterone deficient patients?
That's not dementia, so I wasn't going to cover that. There's many things that can affect memory, a lot of medications, other conditions, and you may remember last week I said there's a bunch of things I'm not going to talk about because I just can't cover them in 2 hours, either last week or this week. So that's something that I'm going to defer on answering that question today. You had a question, though?
A statement really about the dangers of some of these things. I took Aricept for 4 days,
Yep.
and I lost 6 months of my life, seriously.
Okay. You tried Aricept for 4 days and felt like you lost 6 months of...
I did.
Uh-huh.
I did over my bus for many, many weeks. And then anyway, people need to know that there's danger.
Yeah, and that's not common, but as we say in medicine, uncommon side effects occur uncommonly, but they're real. They're still real. They might not happen to most people, but if it happens to you, they can be quite devastating. And that's certainly, we have lots of drugs that have a 1% chance of a very serious rash. But if you're that 1% of people, you get a very serious rash. You can be hospitalized. I mean, things can happen. So there's a reason that a lot of drugs are prescription drugs, right? Because and those are prescription drugs because they're not just meant for over-the-counter use. Okay, so behavioral symptoms, some of the things you can do, these are things that, again, getting back to Claire's question, modify your environment to avoid triggering certain behaviors. One thing to do is if a person with Alzheimer's disease is having trouble with your memory, it doesn't really help to say, well, Mom, I told you that yesterday. Why don't you remember that? That's not going to help, right? And so it's remembering the dignity of the person and remembering that, saying things that are helpful and patience with a P-A-T-I-E-N-C-E. We have to have patience with the patient, right? Because sometimes it can be very stressful. And eliminating unnecessary medications, and maybe, like you were saying, fixing hormone problems, whether it's testosterone, thyroid, you obviously want to do those basic things. Caregiver education, don't challenge the patient, give them comfort, give them activities to do. I don't need to really know about that stuff here. Let's see, memantine, well, these are like donepezil, so the donepezil and memantine sometimes can help with some of the behavioral problems. Some of the standard antidepressants we use for all kinds of depression can help. Benzodiazepines, you want to kind of avoid that, drugs like Ativan, Xanax, Valium, they tend to just actually worsen cognition and cause sedation. There's a lot of people are tempted to use them at night to help these folks get to sleep because sleep can get disturbed, as I talked about, but the sort of sedating sleeping pills actually can worsen things. Again, we want to avoid antipsychotics if we can, not only in Lewy body dementia, but also in general because they do carry an increased risk of death in people who have dementia. I will say that you'll see this advertised if you ever watch the evening news. You'll see this drug Rexulti advertised all the time because they're obviously trying to create a market for the drug. It is approved now for the last a little bit over a year for some of the agitation that occurs in dementia, and it's related to one of the older antipsychotics, but is felt to have lower risk, and it has been tested specifically and does work in dementia. So there are some side effects that you have to kind of be aware of, and importantly, of course, your doctor has to be aware of as well. So those are some of the things that can help, but are not actually treating the problem, getting at the root cause. We do now have, however, and I don't have too many more slides, so that's good news, 2 drugs that are actually getting at the root problem for Alzheimer's disease. One is called lecanemab. So this is a liquid infusion. It's put in intravenously. You have to go to an infusion center. somewhere and sit for about an hour, and it infuses slowly. It actually removes amyloid from the brain, and this is really for the doctors, but this slide right here shows that if this is the placebo group, this is the amount of amyloid that can be seen in the brain on a PET scan over the span of a year and a half. There's absolutely no reduction in the placebo group. It often will go up a little bit. But in the treatment group, you see a massive decrease in the amount of amyloid in the brain. Well, that's nice, but how do the patients do? Amyloid in the brain is one measure, but that's a diagnostic test, right? It's what we call a biomarker. But are the patients getting better? Well, the answer is yes. So down on amyloid is good. Here on these other ones, these are all measures of how the patient's doing. These are all up as good. So here you see at a year, pardon me. Yeah, that's a year and a half. That these are measures of different kinds of scales that have the patient do this kind of testing, and how do they answer, and can they do their activities of daily living, different kinds of scoring. In every case, this lecanemab or Leqembi markedly exceeded placebo. So these are randomized, controlled, placebo-controlled studies. Some patients just got salt water in their vein, other got drug, you didn't know who they were. It's blinded, and therefore it's reliable. And so, massive differences here. We had an earlier drug that they were trying to bring out called Aduhelm, and it reduced the amyloid in the brain, but it didn't change anything. The patients were no better, and it was very expensive, and it had side effects. So people are like, no, we're just not going to use it. But these two came along. This other one here is somewhat similar. Here you get great reductions of amyloid in the brain on the PET scan here, tremendous reductions, and also improvements in these various categories of how the patients function. So these are really good drugs. We know that if you start early, you're likely to get the biggest benefit. So you don't want to wait till someone's moderate to severe Alzheimer's disease. You want to start it when they're mild, because that's when we can remove the amyloid and make the biggest difference. Is it going to extend their life? We don't know yet, because the drugs are new enough. They've only been around and been tested for up to 3 or 4 years. We need to get data out for 10 years on large numbers of patients. So, we'll all have to stay tuned for that. We hope for that. But getting them early when they're starting to have an Alzheimer's disease, the memory problems, but don't have all these other associated problems yet, that's the time to do this. I mean, there's still benefit doing it later, but you're going to get the best benefit. And I would say this, if they're not absolutely stopping the condition, there is some, progression over time, but it's much less than in the untreated, the placebo group. Okay, in final summary, and then I'm going to take questions. Let's go over what we've talked about the last 45 years. So I've been in medicine that long. I started in med school in 1979. So I'm an old timer, but I hopefully don't have Alzheimer's disease yet. Anyway, over the last 45 years, I've seen huge improvements in the understanding and the treatment of dementias. Not as much as I would have liked, not as much as I thought. We've seen bigger area improvements in other neurology disease areas, but still, we're happy for what we're seeing now. So to review what we talked about, it's useful to classify which one of the 4 types of dementia a person has, because then you can tailor the correct and appropriate treatment for that type of dementia. Treatments often involve more than medications. Social, psychological, psychiatric treatments, including psychiatric medications. For Alzheimer's disease and vascular dementia, there are things you can do to reduce your risk. And we talked about those last week, and if you weren't here last week and you're interested, please go to the church website, salc.church, and you can find the video from last week's talk there. Compassionate, emphasis on the word compassionate and patient. being patient with the person. Personal interactions help. They do help. For Alzheimer's disease, the most common type, we have these new treatments, these infusion therapies, which I don't want to overhype it and say it's a game changer, but it is making a big improvement. No doubt there will be much bigger improvements coming in the future, but we're dealing with what we have now in 2024, going into 2025. I'm excited for what we have. I'm looking forward to the future when we have more. So with that, I'll take your questions now. We have just, looks like 10 minutes left, so I did okay. So, what quick? Claire, okay. I'm going to start charging Claire, because after 3, I tell them you get 3 freebies, and then, I need to see your insurance card after that, because if I mean it's free, whatever. Go ahead, I'm sorry.
So are there people who those leading treatments of patients just aren't appropriate for, who have been diagnosed with?
Right, so Claire's question is, are there people who've been diagnosed with Alzheimer's disease for whom those treatments are really not appropriate? The new ones, right, the infusion therapies, Kisunla or Leqembi. People who have bleeding disorders, rare kinds of bleeding disorders, I would be more careful about. Because I didn't tell you this just for the sake of time, rare complications of those medicines is sometimes you can get little microscopic hemorrhages in the brain, and we have to monitor those with MRI scans. I didn't tell you that because I wanted to get through everything. So, and then also if someone has a brain tumor and has swelling in the brain, they can also rarely get brain swelling. And so if they already have a brain tumor with brain swelling, I would say that would be a contraindication. I wouldn't do that. These things don't apply to most people, but those two are obvious ones. There are probably other conditions that we're still kind of trying to figure out how we're going to use these in our practice today. And so more to come on that. And not all hospitals are offering them that. The issue has been, is Medicare going to pay for it? Because these things are going to be expensive, right? And they require MRIs frequently to make sure there aren't some bad side effects occurring. And they require PET scan testing, which Medicare didn't want to cover until recently. So this is all evolving, and not every neurology group and not every hospital is doing them yet, but I think they're going to have to. They've got to figure out ways to get this going. So the real problem right now is patients need it, aren't even getting it. And I think that's a tragedy. But your question is a good one. What other questions do people have? Wow, silence, yeah. Okay, your hand went up first, so I'm going to call in.
So many of us visit people that we know that have this.
Yeah.
4 kinds. And my question, it relates to something it said there, that personal visits are
Yes.
good.
Yes.
But they don't remember you've been there. So I'm wondering how you come
Yeah. So her question was, I go and visit people who have one of these various forms of dementia. Dave, you said personal visits, interactions are helpful, but they don't remember it, they don't retain it, right? That's part of the condition, right? Particularly with Alzheimer's disease, which so specifically, is a heavy impact on memory, right? They don't remember it. So in other words, what's the use? Right. Well, I think there is use of going. I think that enrichment of people's lives, compassion, love, spending time with them. That there's value to that, and being kind of. Even I just think of my dog. I pet and I talk to my dog. My dog doesn't speak English. He knows when he does bad on a bad dog. He'll do that, right? Or food, he'll come. No, I'm just joking. I mean, I think that's part of what we need to be doing. And I can't quote the scientific studies, but I'm sure they're out there that people's lives, their behaviors, their comfort is just better when they have social interactions. Right? We're so mostly people. Some are more introverted, some are more extroverted, but humans are social beings, and I think having that social contact is really important. So thank you for doing that for your friends and loved ones. I think it is. I think yeah. Well, and then and maybe I'm thinking of our own family, Michelle's and mine, where we we've had issues with these things, and just going in and saying, you know what, I'm gonna stay here with mom for 4 hours. Why don't you, sister, you go do something else. You need respite care, right? So it's taking care of the people who are there maybe at other times, taking care of, giving them a break. There's a book that's called The 25-Hour Day, and it talks about just the burden of you know, caring for people. It feels like 25 hours. There you go. All right, I'm going to let you guys go. Thank you very much.
Thank you.
And I will be around. Okay, thank you.